the first speaker, and that is Dr. K S Kumar, and he is going to deal with two topics. First is how does laser photocoagulation work in retinal detachment, and what are the practical tips of pneumatic retinopexy as one of the management modalities. Dr. Kumar, sir.
Thanks, Dr. Preetham, and I would like to thank you for including me as part of this instruction course and the AIOS for selecting this instruction course. I have tweaked the title a little bit. I'll go with how practical is pneumatic retinopexy first, and then talk about the role of lasers in management of fragmentogenous retinal detachments. I suspect that Preetham himself was a little critical about the role of pneumatic retinopexy when he designed the title, when he put it as how practical is pneumatic retinopexy. I won't be going into the details of, in fact, I won't be dwelling anything about the steps of pneumatic retinopexy, but I would like to, present a present perspective of pneumatic retinopexy, which has somewhat had a roller coaster ride so far, a checkered career, if I can say so. So it's a minimally invasive procedure, as we all know, for non-incisional, uncomplicated. So there's something which is coming here. Somebody is operating from there. So it's a minimally invasive non-incisional procedure for repair of uncomplicated RDs, and the mechanism of action is too well known for all of us to reiterate here. There are specific indications for pneumatic retinopexy and specific contraindications where the procedure doesn't work. We are all aware of these various situations, and also we are aware of cases which are ideal, some which are unsuitable, but we may have to seek recourse to pneumatic retinopexy in exceptional situations, and some where it is possible to do pneumatic retinopexy. So to come back to the topic of how relevant or how practical pneumatic retinopexy is in this era, it's now the focus has shifted from a single operation anatomic reattachment rates to functional success. Now we are no longer looking at anatomic reattachments, we are looking at functional success, where we are calibrating the visual acuity, presence or absence of anisoconia, metamorphopsia, and vision-related quality of life indices. And we are now basing all our thoughts on evidence-based medicine, as well as the newer multimodal imaging techniques, which have shown us that the reattachment is not just an anatomic reattachment, but also we are looking at the finer aspects of that reattached retina in the form of outer retinal folds, persistent subfoveal fluid blebs, and retinal displacement as seen on autofluorescence imaging and integrity of the ellipsoid zone, etc. All of these are imaging biomarkers for a reattached retina, and autofluorescence has shown us that there are two types of retinal reattachment that happens: a low integrity retinal reattachment and a high integrity retinal reattachment. We will go through this in the next few slides, and it has clearly shown that the RPE, which was hitherto covered by the retinal vessel, now whenever there is a displacement of the retina after reattachment, that zone which was hidden by the retinal vessel now gets exposed to light, and there is an alteration in the composition of the fluorophores and metabolic composition of the RPE, and you see what is called as vessel printing. And this is the cause for the various visual quality of life post reattachment. This is what we were discussing. The retina may reattach. The retina may reattach post-surgery, but it's displaced in terms of its clock hour position. And that is what, Now, that is what is seen as hypofluorescent lines, the vessel markings on autofluorescence imaging. So the pneumatic retinopexy has been clearly evaluated in the pivot study, where patients who underwent pneumatic retinopexy had better best corrected visual acuity, less vertical metamorphopsia, less incidence of morbidity in terms of cataract, and better mental health and vision-related functioning scores. So that is a randomized double-blind trial which has clearly proven the role of pneumatic retinopexy. And also with swept source OCT, pneumatic retinopexy has shown elegant figures where several 5 stages of reattachment of the retina has been depicted as to how the retina reattaches post-pneumatic retinopexy. It's an outside in, where the RPE pump is relied upon, contrary to inside out as we do in vitrectomy and a fluid air exchange, where there is high surface tension, high buoyancy, and that can cause what we just discussed in the form of retinal displacement. Whereas the retinal displacement does not happen with pneumatic retinopexy is what these swept source OCT studies have shown. What is seen is immediately after the gas injection, there is an increase in the subretinal fluid and then progressively over a period of weeks, there is the reattachment, and then the development of there is initially this subfoveal detachment, and that settles over 6 to 8 weeks. Elegant OCT pictures that are seen post pneumatic retinopexy. So eyes with pneumatic retinopexy have lower incidence of all of the retinal morphological changes as compared to vitrectomy or a scleral buckle. And now there is talk of minimal gas vitrectomy, where there is no fluid endodrainage done at all. There's vitrectomy done, and if there's an associated inferior break, a buckle is put, and it is a pneumatic retinopexy at the end of the procedure, partial filling with gas, and that is thought to result in better visual outcomes. Even modified scleral buckling techniques have been advocated now, where there's no localization, cryo or SRF drainage done. There's only, everything is based on the preoperative assessment. A buckle is put in the quadrant of the tear detected, and paracentesis is done, and intravitreal gas is put. So the focus is shifting even in vitrectomy to minimal gas vitrectomy, not a complete fluid air exchange and gas. So pneumatic retinopexy, there is objective evidence to prove that the type of reattachment that it attains, that it gets for our patients, is much better than that achieved by vitrectomy or vitrectomy or scleral buckle. So these are some of the situations where pneumatic retinopexy can be elegantly employed. And as a secondary procedure, as we are all very well aware, recurrent superior RDs where we can't identify the causative break or ill-supported breaks, or RRD after vitrectomy and sclerotomy related breaks. As extended indications, some of these are also in the list. So these are some pictures which show this is a patient who had a pneumatic retinopexy for an upper temporal macula on RD with good results. Successful pneumatic retinopexy for RD that developed following macular hole surgery. This is what is called as a secondary pneumatic retinopexy, or as a rescue procedure in non-settling RD after scleral buckle, we can employ pneumatic retinopexy. These are some of the extended indications with the schematic diagrams used only in exceptional situations. This is a case which developed almost a giant retinal tear following 20-gauge vitrectomy years ago, and we were able to successfully do sequential pneumatic retinopexy and settle that retina. So pneumatic retinopexy is a friend in need of the vitreoretinal surgeon. We must be willing to do what the retina in question is asking of us, and not do what we know. So a particular retina will be asking for a certain procedure that needs to be done, and we must be willing to be aware of all the options available for that case, and then duly employ that particular procedure, what is referred to as the horses for courses policy. Now, I leave you with this thought. Pneumatic retinopexy is inexpensive and therefore unpopular, or is it inexpensive and therefore unpopular? So we go on to laser photocoagulation in rhegmatogenous retinal detachment. Now, the history of lasers in management of retinal detachment dates back to 1968, when Okun and Sibis first employed employed laser photocoagulation in specific situations, as you can see there. As we all know, it's not a definitive treatment, but can be an expectant therapy to wall off or demarcate or sequester the area of detachment from the rest of the retina as sort of quarantine. May be employed in apprehensive, infirm patients or poor surgical candidates, unwilling for definitive therapy, or lack of resources that may be either financial or medical. So those are some of the indications where we may be able to successfully get away with doing just laser photocoagulation. This is a patient with a peripheral retinoschisis related detachment, or a subclinical retinal detachment in the periphery, where we do overlapping burns, partially overlapping burns, and leave no spaces in between 2 to 3 rows, as the traction is thought to extend beyond the margin of the detached retina. These are some of the situations where we may be able to wall off the inferior detachments. So the limitations are that it's a stopgap arrangement, and counseling is vital, that the patient may need a definitive procedure. There is no well-defined criteria about indications. There are issues related to treatment per se, in the form of field loss and epiretinal membrane formation, full thickness macular hole formation, etc. Constant follow-up is needed, but even so, it's a simple, time-efficient OPD procedure, inexpensive, and it doesn't need any really trained personnel. Even those with a basic knowledge in medical retina can do the lasers in specific situations. Observation versus laser, the role is not proven really. Remote areas with poor access to medical care or underserved areas, some degree of additional protection may be afforded by laser in these situations. And rare instances of reattachment have also been described following laser, where the PVD that occurs post-laser, the vitreous itself plugs the break and the retina may attach. So those are some of the fortuitous cases, chance occurrences. Lasers after retinal reattachment, of course, we do employ post-scleral buckling, post-vitrectomy as an endolaser procedure, post-pneumatic retinopexy also many times where cryo is not employed in the initial steps of pneumatic retinopexy. We may reattach the retina and then do laser after the retina is attached by making the patient's head turn away and move the gas away. Transscleral diode retinopexy is also possible through buccal elements. So these are some of the situations where a shallow peripheral RD can be delimited with lasers, or an inferior RD where we now wall it off with laser. Angioma-like lesions, whenever there is a heavy photocoagulation done, has been described. This is from the literature, and I would conclude with